I'm Damon Fisher. I'm your host for this next session. Uh, look forward to it. I'm the father of 19-year-old Owen, and we've had some amazing sessions, and we look forward to hearing from our next speakers. We continue the information on epilepsy with our next session, PURA-related developmental and epileptic encephalopathy, phenotypic and genotypic spectrum with Dr. Katrine Johannesson and Dr. Guido Ruboli. We look to researchers and scientists for information about PURA. We wait for information. We want to understand everything possible and are so grateful to those researchers and scientists for their dedication to our families. Dr. Johannesson is an MD, PhD from the Danish Epilepsy Center. Her previous work includes papers on ion channel disorders. She has been working with PURA for the past 3 years in collaboration with the foundation, and many may have met her at other social events. If you saw her photo on the website, you would have seen her holding a baby sheep, and she has a human side and life outside of the lab. Katrine is a mother of 3, aged 4, 7, and 11, and lives on a small homestead with her family. She raises sheep and chickens and even has a small yarn making business on the side. She loves anything yarn and wool related and is an eager knitter. Dr. Ruboli is a neurologist and epileptologist working at the Danish Epilepsy Center in Nederland, Denmark, and he is appointed professor of clinical epileptology at the University of Copenhagen, Denmark. His clinical activity involves primarily adult epilepsy, difficult to treat epilepsies, genetic epilepsies, and epilepsy surgery. His main fields of research include clinical and neurophysiological phenotyping of epilepsy syndromes, phenotype-genotype correlations of genetic epilepsies, pre-surgical evaluation, neurophysiology of epilepsy. He has organized several national and international meetings focused on the pathophysiology, diagnosis, and treatment of epilepsies. He is currently co-chairman of the Epilepsy Scientific Panel of the European Academy of Neurology, and he is member of the ILAE Task Force on Transition and Care from Childhood to Adult. He is tutor and teacher at the Virtual Epilepsy Academy of the ILAE and member of the Epicare European Reference Network. We will take questions at the 3:30 breakout session. Please use the Q&A button at the bottom of your screen to ask your questions. Katrine and Guido, thank you for being here and welcome.
Thank you, Damon. I will see if I can share my presentation. So thank you very much for inviting me to talk today. I'm happy to talk to you. I will present a study that's been quite a while in the making, but hopefully we will be able to publish it very, very soon. It has the complicated title of PURA-related developmental and epileptic encephalopathy, the phenotypic and genotypic spectrum. So I will try to take you through the study and tell you what we've found and what we've done. So first of all, this study came about another study that we did where we looked in our adult population of epilepsy patients at the Epilepsy Center, and we looked into how many we had genetic tested and how many where we actually found a genetic diagnosis. And as you can see on this slide, PURA was actually one of the genes where we found 2 cases, where you can see a lot of the other genes, we only found 1. And I want to present you to Peter, which is one of the 2 adult patients we have at the Danish Epilepsy Center. I had the joy of meeting Peter a while back, and he's a very pleasant 39-year-old man. So this is the patient side of the story. And then we went on to think about what we wanted to do with PURA. We wanted to look more specifically at the epilepsy phenotype, collect data on patients, including age at seizure onset, seizure types, treatment response, and EEGs. And we wanted to do this from a large cohort of affected patients. So through the PURA Syndrome Foundation, actually, as well as some of our international networks, including geneticists and epileptologists, we included patients with mutations in PURA. All data was collected in a standardized way and included all these features, seizure types, e.g. neurological features and things like that. We also looked into the treatment response, and we defined it as written here, where seizure-free is only those patients that have been seizure-free for more than 6 months. All the EEGs that we received were evaluated by 2 neurologists, Guido being one of them. We also, in this study, decided to include all patients that had been previously reported in the literature. So we included those at least from papers in English. So in total, we were able to add 67 unpublished patients and 75 patients from already reported from the literature, making the total cohort reach 142. So quite a large cohort, we think, at least. Some of the lovely children and adults are seen in this picture, and these photos are, of course, shared with consent. The one thing I want to point out was that the median age of inclusion was 6 years. So if you take an average, the patients were 6 years, but the range was quite wide. So we had patients that were included at 5 months, and we had those that were 48 years. So it was quite a wide range. Additional limitations to this study include the fact that this is a retrospective study, so we only collected data at one point looking back. We didn't have any longitudinal follow-up, and all data was based on the clinician's, the neurologist or pediatrician's assessment. So, first, we looked into the neonatal period of these children, and what we can see is what is most likely familiar to you, that these children are hypertonic, and thus they have sometimes respiratory difficulties. They definitely have feeding issues. These things are most likely related to the hypertonia. So these children are what you would call floppy babies in the neonatal period. Some of them also had hypothermia described. However, this was only a minor subset. Hypersomnolence, that is very sleepy babies, were described for a lot of patients as well. Looking further into the development of these children, we looked at the developmental milestones and tried to investigate when different milestones were achieved and how many of the patients achieved these milestones. So for instance, in the first row, we have head control. So you can see that 47 out of the 142 patients achieved head control, and this was at a median of 16 months. And so if you look down through this table, you can see that as we progress from minor milestones, you could call them, such as head control and rolling over, to more advanced milestones, such as walking with assistance or walking independently, the numbers go down. However, you still have to bear in mind that a lot of these patients are still young. So perhaps they haven't reached the age of which they will start walking yet. What I think this table really shows is that there is definitely there is a lot of potential in these children, and that actually a lot of them will progress, albeit they will do it at their own slower pace than regular kids. Then we looked into also going into childhood and adulthood. What were the neurological features of these individuals? And again, we saw that hypotonia was the major common issue in these patients. Epilepsy then also started to become a major factor, and then there were other minor issues such as non-epileptic movement disorder, a pathological startle response where patients respond abnormally to sound or light or something like that. Nystagmus, which is this eye condition where you have trouble focusing your eye, your eye will have these abnormal movements. Then there is this conjugate vision, or even some patients who has cortical visual impairment, meaning that not the eye, but the brain part that has to interpret what you see is malfunctioning in a way. In the box on the right, you can also see some of the other common characteristics that were seen in a minor subgroups of the patients. These included constipation, scoliosis, which is a crooked back, hip dysplasia. A couple had some cardiac or large vessel anomalies, and some had dysphagia, delayed puberty, or small stature. But again, hypotonia was the major feature. As I said, Peter here, our Danish case, was 39 when I met him. And we also wanted to look into adulthood in these patients. Unfortunately, we weren't able to include that many adults, so only 9 patients were over the age of 25 at the time of inclusion. Again, all of them had hypotonia, low muscle tone. However, 3 of them were capable of walking independently, and 1 could also walk, but with aid. 8 out of 9 were nonverbal. Peter is verbal. He doesn't speak long sentences, but he can, I could understand him even if I had never met him before. He talked to me about fire trucks and stuff like that, so that was very nice. 6 out of 9 had severe intellectual disability, and 3 out of 9 had moderate intellectual disability, just showing that this is a very severe condition. And again, I think all of them had epilepsy. Then we also looked into mortality. As Professor Leventer said in his previous talk, epilepsy is not usually something that you die of. We found that 4 patients out of these 142 were deceased, where 1 died at the age of 15 years due to SUDEP, which also, as Professor Leventer said, is sudden unexpected death in epilepsy, where a person is found death, where examinations, including an autopsy, cannot really explain why they have died. And the underlying mechanisms of SUDEP are still under speculation, like you could call it. Then we had one child that died at the age of 3 years due to a general worsening of the overall condition, also the neurological condition, which ultimately led to a respiratory infection, and respiratory distress was the cause of death. The same thing happened with 2 other young adults who died in their 20s, also due to this respiratory distress after a period where the overall condition just worsened. However, in general, this mortality rate is what is seen for epilepsy in general. So the PURA syndrome per se does not have a high mortality rate. I wanted to touch briefly on the dysmorphology. That's the facial characteristics. This image is from the previous paper by Margot Rangers, where on the left, you see a control child that is a child without disease. And then what they did is that they, through fancy computer software, merged all the images of PURA kids, and then they got the image on the right. So I think that the differences are subtle, but the main dysmorphic features is, again, the hypotonia, which is also seen in the face. So everything is a little hypotonic. There is a high anterior hairline, almond-shaped palpebral fissures, and full cheeks. These are the most common dysmorphic features, which we also found in our study. Moving on to the epilepsy, which was what we wanted to look at more specifically, since all the previous papers had mentioned epilepsy, but had not really shared any details on the epilepsy type or treatment or anything like that. So in this cohort, we found that 60% had epilepsy. At least they had epilepsy at the time of inclusion into our study. And the age of onset of epilepsy was at a median of 3 years. However, the range was really wide. So it was from the first day of life to even 18 years of age. But if you have to look at it in general, the age of onset was 3 years. One thing that we noticed was that the age of inclusion actually ranged significantly between those who had epilepsy, who were about 9 years old, whereas those in the non-epilepsy group were only 4 years old. This is just to say that we cannot be sure that the children in the non-epilepsy group, that they will not eventually also develop an epilepsy, especially with the range of seizure onset being so wide. So that was one of the first things we noticed, that there may be patients out there without epilepsy currently, but we cannot tell if they will eventually, all of them, develop epilepsy. Then we looked into these seizure types, as Professor Leventer also mentioned. So there is a lot of different seizure types. And what we wanted to see was if there was any specific seizure types that stood out. But as you can see here, a lot of seizure types were found in these patients, and even within the one individual. This individual could have several different seizure types. And these included both, if you remember from Rick's small boxes, so these seizure types in one patient could include both what we call focal seizures and what we call generalized seizures. So the same patient can have both seizures that originate from just one spot in the brain, but can also have seizures that like span the entire brain at once, called generalized seizures. Yeah. What we also found, interestingly, was that we saw a subgroup of patients that had these reflex seizures. And the seizure type was described as myoclonic, which is just a short like movement, or atonic, where you go like you lose all tone, muscle tone, or absence, like where you some call them staring episodes or staring spells. So that's what the seizures look like. And usually they occurred in response to some kind of stimuli, either auditory or visual or sensory. So we had patients that had these reflex seizures due to touch, or brushing their hair, or brushing their teeth, or even in response to pain. We also noticed that in some patients, these reflex seizures were only there for a period of time, and they disappeared again. So this is a question for you guys out there: are these seizures some that your kids have ever experienced? Because we had the feeling that they might be underreported, both in the literature, but also in like some of the cases we got where perhaps they had them for a short period of time and then they disappeared, and so they weren't reported. But this could be something that was kind of specific for the PURA syndrome. Then we also tried to look into the treatment response, and this were only for the unpublished patients, so only for the patients that are in our paper and not from the literature, because data was not available. So if you look at the graph, you can see that these were 4 of the most commonly used anti-seizure medications. I'm sure you've all heard of them. And as you can see, if you take one drug such as valproate, yes, there was some patients that were seizure-free or had a seizure reduction, but there were also some patients that had no effect or even had a worsening with the same drug. So really what this figure shows is that we could not find a single anti-seizure medication where the response was extremely good in PURA patients, or even extremely bad. So there was not one drug that stood out as being better than other drugs, unfortunately. We also looked into some of these non-medical treatments that Professor Leventer also mentions. So 6 patients had tried the ketogenic diet. 2 had a seizure reduction, but 4 had no effect. And the ketogenic diet is quite rigorous to keep up with. Cannabidiol was only tried in 2 individuals with no effect, so it's very difficult to say anything for sure about that. Then we also, some patients also tried the VNS, the implantation that Rick was telling about. And it gave seizure freedom in 1 patient and reduced seizure frequency in 2 patients. So it's just to say that these are some options. They have so far been reported in very, very few patients. But I guess future studies looking more into this would be very interesting to see if there's anything there that could be more beneficial in the PURA syndrome. Unfortunately, there is currently no anti-seizure medication that where the mechanism goes directly targets the PURA gene or something like that. So there's nothing precision medicine approach for the PURA syndrome currently. Then I wanted to talk very briefly on genetics. So we all have genetics, we all have DNA in our bodies, and usually all is well and fine. But for some, as you know, there can be either just a small spelling error where one letter in the DNA code is exchanged for another letter, which can cause severe trouble when having to translate the DNA to proteins that actually need to be used in the brain. Other errors in genetics could be if you have like a mistake in the coding sequence that leads to the code being shortened, and thus the protein will either not be formed or will be malfunctioning or shortened or misshaped in some way, which causes, as you know, these neurodevelopmental disorders. So this is the PURA gene. It has these in the yellow bars, the 3 exons, and as you can see, the mutations in this gene are spread all over. The ones in red have epilepsy, and the ones in blue don't have epilepsy, but there really is no difference. So we cannot, based on the position of the mutation, tell you whether a child will develop epilepsy or not. And as I said previously, maybe they will all develop epilepsy sooner or later. And also, we couldn't find any other differences in the phenotype, like neurological features or neonatal features that was related to like the genetic position. So right now we don't have any genotype phenotype correlations for PURA. And I believe that was all I had. The take-home messages is that the PURA syndrome has a very specific neonatal phenotype defined by this severe hypotonia and floppy babies, and that this hypotonia persists into child and adulthood, but importantly, that developmental progress is definitely possible. Regarding the epilepsy phenotype is very diverse. The age of onset ranges from 1 day of life to 18 years. There is a lot of different seizure types, even within the same patient, and treatment is difficult. And currently, it has to be adjusted to each individual as long as precision medicine is not available for the PURA syndrome. And with that, I just want to thank everybody at the PURA Foundation for helping us with this study, especially Mel, who has been invaluable in chasing down people and sending emails, and also keeping us on our toes, which is also great. I also want to thank Dirk and Robert for all the work that they have done, and Diana for sending us a lot of patients. And the nice people in the image on the left is the Department of Epilepsy Genetics and Personalized Medicine, where me and Guido are from. So thank you for your attention.